We do it again.
Good morning, everyone, and welcome to UCT Virtual ENT platform. I am Dr. Divya Pallavi Ramyead, an ENT registrar at the University of Cape Town, and I'll be discussing on epistaxis. So starting off with my case presentation, a female, 53 years old, was referred from our local clinic, reporting of a first episode of bleeding from both nostrils, but more from the right, and posterior more than anterior. She reports that her bleeding lasted for an hour and was around 1 cup in amount. She had no associated symptoms of nasal obstruction, headache, runny nose, sneezing, or itchiness. She had no trauma and no foreign body was reported. She also reports that she doesn't get any uneasiness or unusual bruising, hematemesis, or melena. She is a known hypertensive on 2 agents with an unremarkable past surgical history, no allergy history. She is not an NSAID abuser or does not take any aspirin or clopidogrel. She's a non-smoker, non-alcoholic, and has no family history of bleeding. Her systemic examination was normal. However, we did note that she was hypertensive and tachycardic on arrival. She had a Foley's catheter and bib packed in her right nostril, and upon removal, a flexible nasal endoscopy was performed where oozing was noted from the right middle meatus. The left nostril had normal mucosa and turbinates, and the nasopharynx showed no mass, and even in the oral cavity, there was no palatal mass. A rapid rhino was inserted in her right nostril and inflated, and no posterior oropharyngeal drip or bleeding past the packs occurred. She was then admitted to the ENT ward. On day 1 admission, there was no bleeding past the packs. There was no headache or visual disturbances reported. However, her BP remained high, 220 by 90, and she was still tachycardic. To optimize her blood pressure, we got internal medicine involved, and they added a 3rd agent to her usual 2 agents. A rapid rhino was deflated after 24 hours. However, a leak was observed and therefore reinflated. Her blood results at this point was an HB of 10 and a normal platelet INR, APT, and UNE. On day 2 admission, deflating the packs, there was bleeding and a persistently high blood pressure was recorded. A plan was made to book her on the emergency board for sphenopalatine artery ligation, plus minus an anterior epimodal artery ligation. The operation required only an SPA ligation and it was successful, and she's due for follow-up at the ENT OPD in 2 weeks. So let us have a look on the current literature on epistaxis, one of the most common ENT emergencies we deal with. It is said that epistaxis has a lifetime prevalence of 60%, but only 10% seek medical advice and only 5% have admission. And the incidence is 121 per 100,000 population per year, and 5% account for posterior epistaxis. The mean age is 53 with peaks less than 10 years and greater than 70 years. It is found that that 71% of inpatients are greater than 65 years, and around 24 to 33% are on anticoagulants or antiplatelet drugs. We can broadly classify epistaxis as primary or secondary based on if there is a proven causal factor, childhood or adulthood epistaxis based on the age of 16 years, and anterior and posterior based on its relation to the piriform aperture. As we all know, the common locations for an anterior epistaxis is commonly from the Casselbach's plexus and posterior epistaxis from the Woodruff's plexus. We can broadly classify causes of epistaxis as local and systemic. However, one must note that often the cause can be idiopathic. So among local causes, we can broadly classify epistaxis causes to trauma, inflammation, anatomical defects, even a septal perf or a septal spur can trigger epistaxis. It's important to exclude neoplasms, which can be benign, such as pyogenic granuloma, hemangioma, or juvenile nasopharyngeal angiofibroma, or malignant neoplasms, such as nasopharyngeal carcinoma. We also have intranasal drugs that can cause epistaxis. Among systemic causes, one must remember bleeding disorders. So this can further be divided into coagulopathies, such as von Willebrand's disease, platelet disorders, such as ITP, myeloproliferative diseases, such as leukemia. Amongst vascular abnormalities, very important to exclude is hereditary hemorrhagic telangiectasia, and I'll be coming to that later. Liver disease, antiplatelet drugs, anticoagulants, and parasitic infection can also cause epistaxis. There has been quite a debate in literature regarding, is there a causal association with hypertension and epistaxis? There are inconsistencies in medical literature, and it is mainly limited due to the methodological flaws within studies. It is said that the elevated BP is rather due to anxiety or a white coat syndrome. However, studies have shown ECG changes consistent with left ventricular hypertrophy and the presence of peripheral and cardiovascular diseases in patients with epistaxis. But in a nutshell, one must determine what are the relative risks and benefits of treating an elevated BP, especially in the setting of a refractory or severe epistaxis, as rapidly bringing the blood pressure down can lead to a risk of end organ damage. There are 3 guidelines, 2 French guidelines and 1 British guideline on how to manage epistaxis, but it essentially boils down to the following: donning 3 Gs, gloves, goggles, gown, securing airway, breathing, and circulation. We want to make sure that there's no bleeding going into the oropharynx and airway. We want to make sure in circulation there is no hypovolemic shock. We want to secure an IV access and take the vitals of the patient. And initially, we can perform a Trotter's procedure, where basically we tell the patient to lean forward over a bowl and pinch the anterior part of the nose between the thumb and index finger, and for around 10 minutes, breathe through the mouth. If this fails, then we proceed to other management. So we then proceed to a thorough history with points, as I alluded earlier in my case presentation, a thorough physical examination where we want to exclude any telangiectasias over the lips, oropharynx. We want to examine the patient's skin in the presence of ecchymosis, purpura, and also examine the nails, as in a hereditary hemorrhagic telangiectasia, there is the presence of abnormal capillary telangiectasia. And then we proceed to an anterior rhinoscopy, where we want to exclude any vestibulitis, any septal perforations, septal spur, any mass, nasal mass. And after the anterior rhinoscopy, it's preferable to do a nasal endoscopy, where we can appreciate the posterior part of the nasal cavity as well as the nasopharynx and exclude any mass. And then we proceed to laboratory examination and radiological studies if needed. So the most common lab test that we order is a complete full blood count, where we want to see the hemoglobin, if it's low, what's the status of the platelets, does the patient have HIV, syphilis, or any infectious disease, how is the PT, APTT, and INR, the protein profile, how is the liver function test. Only if we suspect, then we can send for von Willebrand factor antigen and factor VIII activity. And of course, if the patient has bled a lot, we must always send blood for cross-match and blood typing. At our institution, it is a flow chart of how we manage epistaxis. Initially, our main goal is resuscitation, and followed by that, if a vessel is located, we can either cauterize with silver nitrate sticks or give bipolar. But if the vessel is not located, we start off with anterior packs. If the anterior packs fail, we proceed with posterior packs. And if that fails, we then proceed with a sphenopalatine artery ligation or an anterior ethmoidal artery ligation. And in the complete end, if all measures have failed, we proceed with angiography and embolization. So briefly on medical management, we've got two common vasoconstrictors, oxymetazoline and tranexamic acid. It's been found in this study in 2020 that tranexamic acid actually achieves better homeostasis of 78% compared to homeostasis with oxymetazoline, where it's achieved only in 35% of patients. Important about cauterization is to remove all clots before we cauterize. And we must always apply a paraffin jelly to the upper lip in order to prevent chemical burning and staining. We have two modes of cauterization: chemical cauterization by use of silver nitrate and electrical cauterization by use of bipolar. There are complications of cauterization, which includes infection, tissue injury, septal necrosis, especially if one inadvertently applies on both sides of the septum. And this is why it's important to apply cautery only on one side of the septum and wait for at least a minimum of 2 weeks before we address the other side. If cautery fails, we proceed with nasal packing. Important note on nasal packing is that it is contraindicated if there's significant facial or nasal bone fractures or basilar skull fractures, and if there is hemodynamic instability. Posterior packs have evolved with time. Historically, one would use tagged balls and Thompson balls, but now we have a double balloon catheter, which is effective to control posterior epistaxis. However, in resource-limited settings, this is not affordable, and the Foley's urinary balloon catheter helps. Nasal packing comes with complications. Though rare, they include synechia, nasal obstruction, nasal septal perforation if we are packing both nostrils simultaneously, obstructive sleep apnea, and toxic shock syndrome. Now, how long should we leave a nasal pack? There is much literature that does not really define the exact amount that nasal packs can be kept, but it said that it can be kept from 48 hours up to 5 days. In this retrospective study in 2013, out of 148 nosebleeds, there was no correlation between the recurrence of nosebleeds and the use of shorter packing durations. In fact, 85% of nosebleeds were well controlled if the packing duration was 1 to 3 days. And what about when to give antibiotics? So the idea behind giving antibiotics is to prevent infection and toxic shock syndrome. However, there are studies that fail to demonstrate nasal infections, regardless of patients if they were on oral antibiotics or not. And there's a rise in worry in increasing resistant organisms in hospital settings. Therefore, it's been said in studies that antibiotics are to be reserved only in patients who are immunosuppressed, diabetic, or in advanced age. Hot water irrigation is also an interesting concept to stop epistaxis. The idea is that temperatures above 52 degrees Celsius trigger mucosal edema, which then leads to local compression of bleeding vessels and propagates the cascade for hemostasis. Now, if all these medical options fail, we have to then proceed to surgery. So when to do a sphenopalatine artery ligation? This is based on Wexham's criteria. So the criteria is firstly involves persistent posterior epistaxis, which is uncontrolled by packing. Secondly, a hemoglobin drop of more than 4 grams per dl, and or if blood transfusion is required. Thirdly, there are 3 episodes of recurrent epistaxis requiring repacking during a single admission. And thirdly, if there are repeated hospital admissions for recurrent ipsilateral epistaxis more than 3 occasions in the last 3 months. When taking consent for an SPA ligation, we must always include the need of a septoplasty for access, concha-bullosa reduction, and if failure of SPA at our institution, we always consent also for an anterior ethmoidal artery ligation and or embolization if that fails. So the potential risk one must explain to a patient going for an SPA ligation is bleeding, CSF leak, or vital injury, injury to the median nerve, which can lead to decreased tearing, and damage to the nasopalatine nerve, which will lead to numbness over the upper gums and teeth. Contraindications for the surgery includes medical comorbid disease, general anesthesia risk, and coagulopathy. One must remember 3 main steps when going for an SPA ligation. First of all, raising a nice superior still elevated flap. Secondly, locating the crista ethmoidalis. And thirdly, identifying the multiple branches of SPA and cauterizing them. So what happens and what should we do if there's an edematous nose secondary to nasal packing, or the anatomical anomalies such as a deviated nasal septum or a large concha-bullosa, or if there's limited space, the space is crowded due to large turbinates or the above? One mustn't lose hope. One can proceed to do a standard antenectomy and enlarge the ostium posteriorly till the posterior maxillary sinus, raise a mucoperiosteal flap from the posterior maxillary sinus wall, and perform a limited septoplasty and reduce the concha-bullosa. Now, if the sphenopalatine artery is cauterized but bleeding is still occurring, one must look, it could be from the anterior ethmoidal artery. Now, it's reported that in 40% of patients there is dehiscence, and the anterior ethmoidal artery is most commonly located between the 2nd and 3rd basal lamina. There are 2 approaches, the modified Lynch or the precurrenticular approach. There is an interesting paper published in 2018 titled Breaking Paradigms in Severe Epistaxis and the Importance of Looking for the S point or the Stamps point. Now, this is an arterial vascular pedicle which is found posterior to the septal body around the projection of the middle turbinates axilla in the upper nasal septum. Here's a diagram where you can see the vascular pedicle. And this pedicle actually disappears when we apply local vasoconstrictors, and therefore showing the importance that sometimes it's good to have a look in the ear, in the nose before applying our pledget soaked with vasoconstrictors, as this can cause disappearance of this vascular pedicle. There is a nice paper showing the precurrenticular approach to anterior ethmoidal artery ligation, and essentially locating the nasion and the Horner's muscle helps us to identify the anterior ethmoidal artery. In the past, if all these measures failed, would go for a maxillary artery ligation, either through cadval loop or sublabral approach. However, there are complications associated, such as oropharyngeal fistula, facial pain, and even blindness. And if that failed, one would go for ligation of the external carotid artery. However, one must note that there are cross anastomosis between the external and internal carotid artery. So the end, at the end, one can go for embolization. And for this, a pre-embolization angiography is essential to exclude any communication between the internal and external carotid artery. One must note that we must embolize only the external carotid artery, as if we embolize the internal carotid artery branch, this can lead to blindness. And this is especially useful to identify location of bleeding in poor surgical candidates or failed surgical patients. Embolization does come with minor complications such as nasal ischemia or headache, swelling, and major complication even leading to CVA. This is an interesting paper published in 2017, which shows the different treatment modalities. So here, when comparing surgery with packing, it was found that there was higher success with surgical options versus packing. And when we tried to see if the sphenopalatine artery ligation alone is good or associated with anterior ethmoidal artery, there was a 100% success rate when both surgeries were combined. And when they tried to compare surgery versus packing versus embolization, they found again that surgery had a higher success rate. So why is it important for us to exclude hereditary hemorrhagic telangiectasia? So this is actually a condition that occurs 1 in 5,000 patients, and it is an autosomal dominant condition where 95% of these patients present with nosebleeds. There are other bleeding sites such as the skin, lungs, liver, GIT. And we can diagnose this by the Kurakau's criteria, which is based on 4 criteria: epistaxis, which is spontaneous and recurrent; telangiectasia, which is multiple and therefore important to examine the lips, oral cavity, fingers, nose. There can be visceral lesions in the GIT, pulmonary, hepatic, or cerebral lesions. And one must ask, is there a first degree related with HHT? If there are 3 of these 4 criteria, this means there's a definite diagnosis made. The management includes CT brain, CT abdomen, G-scope, screening family relatives. Conservative management includes topical estrogen ointment, saline rinses, tranexamic acid, Avastin, and surgical options include cauterization, argon laser, septal dermoplasty, and Young's procedure. Now, just a little note about pediatric epistaxis. Most common cause in children is nose picking, inflammation, foreign body, or staph colonization. But one must always suspect von Willebrand's disease also. It is common for children who have leukemia or are receiving chemotherapy to present with epistaxis, especially if they have thrombocytopenia. And in older children and adolescents, the bleeding is commonly from the Kasselblatt's area or from a maxillary spur. The treatment initially should always be ensuring mucosal hydration with saline drops, giving emollients such as petroleum jelly, use of antiseptic cream, mupirocin ointment, and chemical cautery. What should we do if patients are on anticoagulant and antiplatelet medication? This is a nice flowchart that tells us that we must, so in both cases, whether the patient is bleeding severely or not severely, we will withhold the anticoagulant and will administer appropriate local measures. However, if the bleeding is not severe, we will consider an oral or IV vitamin K, and we won't reverse the anticoagulant or transfuse platelets. However, if the bleeding is severe, which means there's a posterior nasal bleed, hemodynamic instability, or a decrease in hemoglobin of more than 2 grams per dl, we would then give the reversal agent and assess for other comorbidities. And in the end, if a patient comes with recurrent unilateral epistaxis, it's always important to ensure you haven't missed a foreign body, a pyogenic lesion such as a pyogenic granuloma, benign or aggressive tumors such as juvenile nasopharyngeal angiofibroma, or a nasal malignancy, as these patients commonly present with nasal obstruction in 66% and epistaxis in 55% of cases. Lastly, hopefully COVID's gone, but if not, it is the COVID guideline published in ENT UK 2022, which shows that if bleeding is resolved with cautery and PAC, and there are no criteria such as there's no significant medical history, there's no coagulopathy, the patient is not living far and alone, we can PAC and send them home. These are my references. Thank you for your time.
Well, thanks, Divya. She takes the Two questions. One is, you mentioned in children, you've got the option of simply using cream and certifications and Vaseline. You didn't mention that in adults.
Yeah.
Have any studies in adults that looks at the efficacy of that as opposed to porphyry?
No, that I haven't seen any in the literature.
Yeah, but if you've got anti-epistaxis, it works in children, and likely works in adults. So that's the one issue.
Yeah.
The other issue is that the studies where they looked at packing versus surgery, I think one would just be slightly cautious because they probably were biased in terms of those are probably patients who referred to ENT that had failed. Amongst that possibility. So, because most countries in the world don't have an option of surgery, but people don't like the epistaxis. And so there must be coping. And what happens in your country?
Yeah, we basically do like muscle packing. We have so these 2 hours. And with the inpatient, we also had antibiotics, especially within 72 hours. Few patients will have continuous epistaxis.
And what do you do with those? If you have got the expertise.
Yes, so sometimes we do a second repaction. Yes, so it's 2 days, depends on how bad the bleeding was, and usually that solves the problems. Yes, in rare cases, we've taken patients to theatre for SPA.
Yes, but if it's not common,
It's not.
You know, I'm trained there's a series you take to the theatre for a packing under anesthesia. That you see the packet properly. It's amazing how much ribbon draws you can get into the nose. And so 1.5 meters, yeah, really tight. So what I'm saying is that even though here with a very surgical approach, remember that most of the world people don't have, and then you get away with it. So yeah, what do you do Zimbabwe?
In Zimbabwe, we predominantly take, and when I was training, I think maybe I think once or twice when we take the patients for SPA like but it's predominantly taking until I see a taking up to 5 days. As a patient that we take for 5 days, and so most of the time we have taken them to theatre, and also because theatre time is limited, even for emergency cases, so we try to triage it